Good evening, Juan. Thank you very much, and congratulations on this wonderful meeting. And dear Mike and Dr. Tong, my co-moderators, and all the distinguished speakers and the participants. Good evening, good afternoon, or good morning, wherever you are, or if you are sleeping, sweet dreams. So I was going to talk about the difficult cases, but then Juan asked me to cover the lab training. So I'll try to do both in 25-30 minutes. I have no disclosures other than loving neurosurgery, microsurgery, and practice. This slides, I think, summarize everything about the neurosurgery, and in particular bypass surgery, microvascular surgery. This is at Barrow, and I saw Mike practicing there and helping the participants, and I also sat down and tried my best. So this is the lab, this is the office microscope I have in my office, and I try to use if I have time. And the main thing is practicing in the lab and then going to the OR. And this is the curriculum we have here at the University of Wisconsin Medicine for residents, fellows, and international trainees. I suggest all my residents or fellows to do this at least 3 times during their residency or during their stay, so they get better and better every time. The first step is the Penrose suturing, mimicking the arteriotomy closure in carotid endarterectomy. Starts with the 6-0, and then they go to the 7-0. Every time it's 6 centimeter length, and every time they note the time and they record their video, and we score this. And you see that one of the trainees first practice with the 6-0, and then the last practice with 7-0. There's a big difference between two. So you get better as you practice, as obvious. And the second step, doing the fake vessels, and we also a system model we can use, try to simulate the real-time surgery with the pumps and other things. And this is end-to-end, end-to-site with the 8-0, 9-0, and 10-0 practices, exercises. And then after the fake vessels, they go to the chicken tie with the end-to-end, end-to-site, side-to-site anastomosis with 10-0 nylons, and they complete this, and then we score them, and if they pass, they go to the next level, which is the red femoral artery, carotid artery, end-to-end, end-to-site, side-to-site anastomosis with 10-0 nylons. And then again, they record these, and I score, but believe it or not, other than many international trainees, residents don't have interest in these anymore, and they used to do more and more. Now it's just we ask them to do, but not many of them unfortunately go to the lab and do this. And then there's also alternative practice methods. If you are in the operating room every day, you can use the operating room as a practice, but we also try to develop the practice models for the people who cannot access to animals or other high-tech stuff. So we have a grapefruit model, and we stimulate the side-to-side A3 bypass. This is recently published in World Neurosurgery. You can watch the videos on this. This is a nice, neat model. Ulash, one of my fellows, came up with this model, and we developed this as grapefruit. It looks like basically a frontal interhemispheric area, and then you dissect that, and then anastomose the fake vessels side to side. And there's also this method I learned when I was in Japan, a fellow with Dr. Sugita, suturing the gauze, and this is very easy, cheap way of doing it. And this is first thing they asked me to do when I went to Nagoya as a fellow. And then this is my dear friend Junichi Yamamoto from Albany, and he came up with this, his wife's cake maker, and then you can go deeper and deeper and then the practice the deep anastomosis and then there also for residents, fellows, opportunities during the lab, during the surgery, after the main bypass is done, they can use EDAS part, suturing with the 8-0, 9-0, or 10-0, performing these dissections and suturing before they go do the real practice in the anastomosis. And as you guys know, Yashar introduced this closure of the arachnoid in Sylvian fissure or the cisterna magna. And this is the recent case of the brainstem cavernoma. We operated, and I asked my fellows to, fellow and the chief resident, go there and practice the 10-0 suturing. It's a deep field, is nice practice, is not harmful, and is good time to do something for the chief resident or residents or the fellows. So there are many things you can do. You can go to the lab and clean the P arachnoid of the cadaveric head. And these are all practices. Or you can do surgery in insular glioma, and that's also microsurgery. That will help you to perform also bypass surgery. And then now the next part of my talk, indications for bypass and some difficult cases I would like to show you. Now is today we are in the endovascular era, and we do less and less neurovascular cases, open surgery. And it becomes hard to keep up with your skills. But if you do intracranial microsurgery, believe me, eventually it pays off. You don't need to do 10,000 bypass. You don't need to do 10,000 clipping. If you do GBM, the way you're going to do AVMs is microsurgery. Why we do the indications for bypass? Flow augmentation, flow replacement, and prophylactic or protective prophylactic. And there are so many ways of doing it. Mike is championing doing the in situ bypass and others, and everybody come up with something else. So whatever you do, you just need to be aware. There are many bypass conduits hasn't been taught about it. So how I do my bypass, I learned this from when I first went to Helsinki live course from Rokia. I start STA harvest with under the microscope. It's more efficient, more clean, very dry, and I use very low intensity Colorado tip, micro tip electrocautery. It dries it and it helps you to dissect, and it gives you very bloodless dry field, and you see better, and your graft, a superficial temporal artery graft, remains healthy at the end of the harvest. Sharp dissection, blunt dissection, whatever it works, but eventually you get the clean, nice STA. So, and then next step is doing all these steps. I always like to start with the aspirin, at least 81 milligram baby aspirin 1 week before surgery for elective cases. If it is emergency, I will give them right before the surgery. And I always give before the temporary clipping 1,500 to 3,000 unit IV heparin, depend on the patient's weight. Continuous IV irrigation with the heparin, and covering all the vessels with the warm nitrite, sodium nitroperoxide soaked gel forms, perfect adventisectomy. Try avoiding the pinching or squeezing the vessels, and I like to use the interrupted sutures except side-to-side suturing. And we have this Wisconsin broth invented by the vascular cardiovascular PA, who did like 20,000, some crazy number of vessel harvesting. So we use patients' own blood. We don't avoid blood, and I don't distant any vessel with any irrigation or anything like that. So a couple of examples. First, straightforward examples: Moyamoya disease. Dr. Kawashima showed nice cases. I don't need to go over the indications. In Moyamoya, I learned in Japan. I like to do at least a direct bypass if feasible, and EDAS combined with the EDAS, and then also I do frontal burr hole in cases that I suspect anterior cerebral ischemia or low perfusion with the pedicle pericranium. And this is a case who is actually Japanese, who had the surgery when she was a child, moved to United States, presented with basal ganglia hemorrhage, and this case is published somewhere. First, the direct bypass, and then EDAS with the parietal branch. And EDAS, the way I do, I put sutures into P arachnoid and tuck to the branch to the brain cortex, and also suture to the dura, that parietal branch. And good results, and she's been doing very well. Cerebral ischemia, same way. In cerebral ischemia, depends on the perfusion studies and the patient symptomatology. I like to do double barrel bypass, and this is the one case I always map. So this is the case. I'm going to show you. I use two branches at the end. It's going to look like this. For time purposes, I'm just jumping this. And parietal branch and frontal branch, and this patient has been treated with multiple treatment modalities and kept having the symptoms, and after the bypass, no TIAs and only on aspirin, and she's been living symptom-free at age 75. And these are the rare cases, and this is the 62-year-old woman with previous carotid endarterectomy, rest stenosis, stenting, and finally occludes and gets stroke, and then continues to have TIAs with the low pressure or exertion and significant perfusion deficits in the left hemisphere, in spite of multiple trials of the medical treatments. And if you look at the dynamic studies from the contralateral injection or the STA or the CTA, there's really no internal carotid artery, common carotid artery, or external carotid artery. Nothing you can find. There's no filling of the STA from the contralateral side, no post-auricular arteries, and this patient is severely symptomatic. Anytime she sits up or try to walk, she gets symptoms. So what are we going to do? What kind of options we have? You can do vertebral artery to MCA, or so-called bone bypass introduced by Dr. Spetzler in 1980. So bicoronal incision, harvesting preparing the contralateral STA, simultaneously vascular team gets the endoscopic harvesting of the saphenous vein. Difficulty in this, it's not technically challenging case, but is mentally challenging. You have to go over every single level, every single step in your mind, because it's tough to estimate, number one, the true length of the graft you need, and you have to create a groove on the frontal bone, and then you have to perform the proximal bypass first, contrary to the other bypasses we do. And this is again is a good example, is good practice cases for the fellows. Is there's no ischemia time, and very atherosclerotic STA. You see, you have to get all the layers, and since there's no time concern for ischemia, with ATO sutures, fellows or the chief residents can perform safely if they are good enough for this. Once it's done, you backfill the STA, you create a groove in the bone and tag the saphenous vein, check the back bleed, and then you are ready. But this brings also risk for air embolism if you don't get the air out before and you don't need fish mounting for the saphenous vein, and to overcome the mismatch, you make a long arteriotomy in the recipient MCA and perform the bypass. Then once the bypass is done, you take everything and you need to check the, you need to get the air out. So you have to make a small opening in the vein, and then take the clips and get the air out. And then you have to close that with the also suturing. This is her bypass, and she's been symptom-free 2.5 years only on aspirin, and the bypass remains patent. So, and another area is the iatrogenic injuries. As you know, this is a 70-year-old man with this is his third surgery at outside hospital for recurrent residual tuberculum cellular meningioma. When they are removing the tumor, they experience a profound, severe bleeding from in the field. They throw the gel foams and close the case. There's an infarct in the ACA territory, also pseudoaneurysm. They transfer him to us, and pseudoaneurysm is growing. Question about doing the covered stents, flow diverters, I think is the, you can get by with sometimes, but is the most of the time, I think you need a definitive treatment, which is a trapping and the bypass. And that's what we did, radial artery graft and the trapping. And he was in DI, and we stabilized him post-op day 3, post-op 2 months. And now we are in the endovascular era, and this is the case done by one of my partners, ruptured ACAM aneurysm. He clips the aneurysm, patient develops a severe vasospasm, and he takes the patient to hybrid OR, performs the angioplasty. During the angioplasty, he realizes extravasation of the blood, and he called me immediately. So luckily we are in the hybrid OR, everything is ready. We turn endovascular case to do open surgery. And luckily again, he wanted to take this with balloon, or coils occluded completely. I said, just wait it until I get there. And he opened until I get there. Of course, it's chaotic. We couldn't record the entire video, but there was a couple of millimeter tear in the distal M1. So I was able to control the bleeding and put 3 and 10-0 nylon sutures. And so this is not a bypass, but is like a bypass. It's life-saving procedure, especially if you are in the hybrid angio suite, hybrid OR. This is the perfect case, and we used that, and it worked out very well. And believe it or not, patient did well. And in aneurysms, yes, clipping, coiling, flow diverters, but we'll still need a bypass procedure. This is a 62-year-old woman, 2 sessions, each session 12 hours, 24 hours, 3 endovascular guys, excellent endovascular surgeons, try to flow divert this aneurysm, and every time they failed. And this is my poor drawing and writing explaining patient what we are going to do. So since she failed, and this is a fusiform aneurysm, giant aneurysm of the posterior communicating artery segment of the ICA, and so I offer her a bypass trapping, and that's what we did. As we first expose the aneurysm, find the expose the Sylvian fissure, find the recipient artery, atherosclerotic vessels, perform the bypass first from radial artery to M2, and then after the bypass, we will explore the aneurysm, and you need anterior clinectomy in this case. If possible, I like to trap before the distal to the ophthalmic artery to preserve the ophthalmic artery flow, and then the last trapping clip should go proximal to the anterior choroidal artery. And again, high bifurcation. Our vascular, peripheral vascular colleagues use these vascular points. They are very useful. makes a very good arteriotomy, but this patient is quite atherosclerotic, didn't do a good job. I'm extending that hole and making almost elliptic. And sometimes in this common carotid or external carotid in elderly atherosclerotic patients, 8-0 doesn't work. You may need to use 7-0 or 8-0 with the big needles because it's very hard to pierce the artery wall. And that's done. And now we are going to perform the extradural clinidectomy, which I feel more comfortable doing in these cases, and then go intradural, cutting the falciform ligament and exposing the ICA distal to the ophthalmic artery. Once the ICA is exposed, now we are ready to take the temporal clip from the ICA in the neck and move to the head and place the temporal clipping on the ICA. And clipping the PCOM. PCOM is not fetal configuration. Clipping the ICA distal tube, bypass is working. Now it's time to decompress the aneurysm. Aneurysm bleeds, looks like bleeding, but I think it's trapped vessel, and patient had severe optic nerve compression. So I just decompressed to open the aneurysm, and this is the results. And she's been doing very well. And fusiform aneurysms, this is a 10-year-old proximal pericallosal aneurysm, and pericallosal artery comes out, very small. So what are the options here? There's no endovascular options. Don't even think about it. Reconstruction, clip reconstruction is not possible. Simple trapping, maybe. But we did the dynamic angio, posterior circulation. There is no good posterior pericallosals filling the. So it's very likely he's going to fail, but we'll defer that to the surgery. And if we do bypass trapping, A3, but see the distance between two, or STA to A3 bypass with interposition graft with either radial artery or saphenous vein. We studied this well, and we prepared the leg, arms, everything, and plastic surgeons, everybody's on board for this 10-year-old, and we extensively dissect these STA branches. Then it went interhemispheric, expose the aneurysm first, try to do the A3 bypass, or at least see is it feasible. You see the difference. I dissect these branches many times. It's no way I could bring the together. And then I put the temporary clip and I do the ICG green, not simultaneous flow. So it's simple trapping is not possible. And we measure before, during the surgery, 18 centimeter interposition graft we need. And plastic surgeons start harvesting the graft. And while I am getting the proximal control, and once we clean, we realize there were several holes in the radial artery, and it turned out to be radial artery is only 12 centimeters. In spite of all these calculations and the pre-op and intra-op evaluations. So we decide to first do the bypass and then mobilize the frontal branch so I can overcome the short interposition graft, but there's a big size mismatch. And we use the dilators, plastic surgeons, microvascular surgeons use in spite of that. So I did this tapering technique of oblique cut and making the radial artery smaller. So it fits like this here, you see. So ICG green work, and he did very well. Post-op day 3, post-op angiogram showing the filling of the A3 from the bypass interposition graft. He's back to school, he's happy, no headaches. All the swelling is gone from the thrombosed aneurysm. This is a recent case of the fusiform aneurysm, 70-year-old, no subarachnoid hemorrhage, multiple dysplastic vessels, and large ACOM and large near giant size distal MCA aneurysm. So if you study the angiography well, one artery comes here, goes under, another artery comes here, and then I try to locate the angular artery at surgery, and I found it, and it's very deep and distal part of the fissure. So first I did the bypass with the STA, parietal branch, to do this angular artery. That's done. And then I exposed the aneurysm. And when aneurysm exposed, I realized there is no way I can get inside to bypass and something else with this branch. So I trapped this branch, but luckily I created space here. I put another clip here, and then I put the angle fenestrated clip to fenestrate the other branch like this. So this is the area I thought I can put the clip. This branch is trapped, that's the angular artery, and I'm creating a space, and this clip looks good, excluding the aneurysm, angular branch here, and the bypass is done on that branch and looks good here. And then we go to this artery, see, is coming from the this fusiform dilatation of the artery, part of the aneurysm, fenestrating that, and that worked very well. And this is post-op day 1. Bypass is working, no stroke, and you see the bypass, and we exclude the aneurysm and also clip the ACOM aneurysm. This is another recent case, morbidly obese, grade 5 subarachnoid hemorrhage from the pica dissecting aneurysm, and it's hardest ever case I have done. Many reasons: very steep posterior fossa, very thick bone. It took us 3 hours to do craniotomy, because once we did the posterior fossa craniotomy, this steep angle didn't allow us to do any dissection. So I have to take this entire bone and nuchal line, make it flat to get the view. And then another difficulty was, look at the pica loops, how high they are. My initial idea, if I can, I would like to pica bypass. If not, occipital artery pica bypass, but due to the morbid obesity, there is no way I could find the occipital artery. Then we already prepared the leg and the arm. We went for the radial artery, but once it's exposed, you'll see there's no way I can do the radial artery. I had to resect the tonsil, ipsilateral tonsil, find this ipsilateral pica, and there's retractor there. It's very steep, and while I'm preparing for this, a million people watching, and the plastic surgeon says radial artery was perfect. Right before the harvest, it got thrombosed. What are we going to do now? Luckily, I knew we can use the cephalic vein, and I think it's published before. And we harvested from the same exposure the cephalic vein, and we did the cephalic vein. Is huge vein, you see, V3 to pica, and then the trap the aneurysm. And he was grade 5. Everybody gave up on him but me. And 6 weeks, 3 months, 8 months, and he's still improving, and robust bypass. Mycotic aneurysm is the same story as submillimetric vessels. You can do inside to bypass here. This case is published. You can watch too. It's very small arteries. We found an en passant artery parallel to the. So we did the end-to-end and end-to-side, inside to bypass, and get rid of this dominant hemisphere M3 mycotic aneurysm. Traumatic aneurysm is the same story. Don't put any stents in these. They don't work. And you can do double barrel bypass, juvenile rheumatoid arthritis, suicide attempt, and depression. And now his bypass is working due to frontal lobotomy bilaterally. He's not depressed anymore, happily living. And blister aneurysm, same story. Blister aneurysm to me is the bypass therapy case. I'm stopping. And if this happens, just keep calm. And sometimes there are blister aneurysms in different various types. So you have to trap it, or you can do bypass prophylactically and then explore the aneurysm. And if you can clip reconstruct with restenosing the artery, you can do that too. That's what we did here. And it's 80% of, maybe 70% of the lumen stenose, but it's patent, it's grade 2 subarachnoid hemorrhage. We didn't give up on the artery, and good results. Skull-based tumor, same thing. You can do these with the bypass, radial artery first, and then the cavernous sinus exenteration in 3 stages. This patient had 6 surgeries, multiple radiation, many experimental therapies for grade 2 radiation-induced meningioma. And in conclusion, go to the lab, start in the lab, mentally prepared, you have multiple backup plans. There are many ways of doing the bypass procedures. Learn from the other disciplines like peripheral vascular, cardiac vascular, or ENT colleagues, plastic surgery colleagues, and go to lab. I hear, I forget, I see, I remember, I do, I understand. Go listen. I still watch, and I will still learn. And today I'm going to learn from the other masters. Thank you very much.